This is Chapter 5 of the W&Kelley textbook. So once you have gathered your data, then the next step is a diagnosis or analysis of that data. So that's the second step of the nursing process. And the end output of that is going to be nursing diagnoses and basically a care plan. The nursing diagnoses are kind of the core, the heart of the care plan. And we have several different types of nursing diagnoses. We have health promotion diagnoses, which are not a problem. They're strengths that you diagnose. But we also have risk diagnoses, and they're also not an actual problem, but they're a potential problem. We have collaborative problems and referrals, which mean that the nurse is not going to handle those problems independently. They will either handle them in collaboration or maybe completely hand them off to someone else. And then we have actual nursing diagnoses, and those are probably the most common type. They're the ones that the nurse is going to handle pretty much independently. There may be a little bit of collaboration in there, but for actual nursing diagnoses, the nurse is probably going to handle those pretty much on his or her own. Some of the essential elements of critical thinking: number one is to keep an open mind. If you go into a situation, say for example, you have one situation might be if you have a sickle cell patient, you will hear nurses saying, oh, yet another sickle cell patient. She's just going to be after me all night for pain medication. She's going to be exaggerating her pain. And so that's going into the situation with a closed mind. And I can almost guarantee you that that nurse is not going to develop a good care plan. He or she is not going to take good care of the patient, and it's just going to be a bad outcome. And sometimes it's really hard to avoid this, because sometimes you'll have maybe 9 or 10 patients that all fall into a certain pattern, and you may be getting into a rut yourself, and then the 10th patient comes along that's the one that upsets your whole mental framework, and you just don't have the time or energy to deal with it, and so you keep your mind closed and miss your opportunity, and it's a bad outcome. Another essential element of critical thinking is you should have a rationale to support decisions and opinions. For example, striking very close to home, when you get an answer wrong on a test and you want to challenge that answer, many times I'll get an answer where the student says, well, I thought it was this, and they don't give me any rationale. So really and truly, I don't spend a whole lot of time on those kind of challenges. I just probably send you back an email saying, look on page 24 of the book. Now, if you have a rationale, even if that rationale is wrong, I'm going to spend more time and attention on explaining the answer that was given. And I will have a lot more respect for you as a critical thinker too, and as a student. Reflect before coming to conclusions. That's key. A lot of times we're pushed for time and pressed for time, and we think, well, I have to finish this care plan because I need to move on to other things. But that runs the risk of jumping to a premature conclusion, and it's really better to leave things open than to jump to premature conclusions. You can always develop a care plan and maybe not leave some things open for later, and then later on when you're less stressed, you'll be better able to come to a good conclusion. And then another essential element is using past clinical experiences, whether they're good experiences, bad experience, whatever, to build your knowledge. I remember the case of a student. This was in a foundations class, and the student was going to give a first injection and really botched it. I'm sure the student felt terrible because the student kind of pricked at the person and didn't go in, and I kind of had to guide the student to complete the process, and it was a bad experience, I'm sure, but that student got some valuable learning out of that, and the end result was that I recommended that student for a clinical excellence award on the basis of that whole experience. So sometimes even bad experiences can be very valuable. Another element is continuing to build an adequate knowledge base. For one thing, nursing is continuously expanding. I mean, what's in your textbook right now is already outdated. There are further findings being made every day. So you can't just stay still with the knowledge you have. And for another thing, even if the knowledge in the field isn't expanding, if you just stay still and rest on what you've already gained, your knowledge is going to get stagnant. You'll become bored and burned out. Even if the knowledge itself isn't changing, the whole cultural context around I certainly do not practice nursing in the same way I did when I first graduated. It would be really disastrous to try to do so. So you have to, and you things that you learn maybe are right for the time, but then as the field advances and as culture changes, why it's going to become outdated. So you have to keep learning in order to keep up. Then another thing is awareness of interactions with others, your interpersonal knowledge. And it's easier to see people that fail in this in others than it is in ourselves, unfortunately. I'm sure have a friend or relative or somebody that is, if you take them to a party, for example, you want to kind of hover over them because you say, well, if I turn him loose, he's going to say the wrong thing to people. He's going to just be totally unaware that he's offending people. He's probably going to just make a mess of things. So I have to kind of keep on top of him. And this becomes heightened in the clinical setting because it's a very unfamiliar environment. Probably for you. Maybe some of you may have some experience in the clinical environment. You may have worked in hospital settings. Most of you have not. And some of you may have been in the clinical settings as a patient. And so you're going to have a great sensitivity. It's quite eye-opening the first time you become a patient after you've been a nurse. You think, oh, I've been doing that all this time? Why, how offensive, and nobody ever said anything to me. there you'll become a lot more. It's probably a good thing to have a hospital stay. I don't wish it on you, but it's quite eye-opening. It really is quite eye-opening to spend some time as a patient. And it's quite easy for us. For one thing, patients don't want to offend us. They feel like we're their lifeline. We're controlling things. If they think if they offend us, why, some don't care. Some are quite, outspoken and don't care about that. But a lot of patients don't want to offend us. So we may unconsciously do or say things that are insensitive, and nobody even tells us. And and then they also make allowances for us. Well, they'll say, oh, well, she's busy. She just doesn't have time. She's, busy and all this. And maybe we're not. Maybe we're not truly busy at all, but they do make allowances for us. So you want to be aware of those subtle indications people have that maybe they're a little bit disappointed in us, or that maybe they didn't understand really well what we said, or all these kind of things. Don't be and it's hard at first because you're focusing on so many things, but when you do pick up on something like that, pay attention to it. Pay attention to it and try to learn from it. And finally, awareness of the environment. And this is another thing that at first you're kind of overwhelmed. You're in this, new environment, unfamiliar environment, and you don't even know the names of half of the things you're seeing, and you don't understand how the social interactions work. You kind of have a vague notion of what a doctor does, what a nurse does, what a respiratory therapist does, but several years later you finally start putting the pieces together, and you have an understanding of what a hospital environment is all about. So that's important for critical thinking too. The book gives us various questions to ask about ourselves, and these are kind of reflective questions and to ask yourself in order to improve your critical thinking. So one of them is, do I reserve judgment until that information is complete? I mean, you can't reserve judgment forever. There comes a time when you do have to make a judgment, but probably it's more common for people to make their judgments too quickly than to wait too long. So probably the answer is yes, maybe I do reserve my judgment, but maybe not long enough. And that is true for me too. I don't think that I'm some perfect critical thinking guru. I fall into a lot of these traps, and I have nurse-patient relationships that become a problem, and there I'm not a perfect critical thinker by any means. Next one, do I support my opinions with rationales? And it could be either something I see, or it could be something in the literature. And there's not anything foolproof there, because you could, see something and misinterpret it and still get it wrong, and you could read literature that's faulty and still get it wrong. But do I support my opinions with something? Remember that student that objects to a test question and doesn't provide a rationale. Whether the rationale is good or not, it's much better to have a rationale than not to have anything. Then, do I explore alternatives before I make a decision? And a lot of times the decision seems pretty clear, but it's usually best to consider alternatives, because even though, like, you come up to an intersection, your intersection, and there's a four-way stop sign and everything looks pretty clear, but there could be a kid hiding behind one of the, or that not hiding, but there could be a little kid behind one of those parked cars that is running, and as you get into the intersection, that kid dashes out in front of you. So, you consider alternatives. Always consider alternatives. And then, do I distinguish between fact, opinion, cue, or inference? So, and certainly, we have some empirical facts, that's one thing. Opinion could be either expert opinion, which is well founded, or it could be someone else's opinion. Like maybe you just decide to, I'm going to Google what this disease is, and you happen to get some conspiracy theorists blog, and they tell you that it's a big hoax developed to sell drugs or something like that. So you could get an expert opinion, which is a little not quite as good as a fact, but better than nothing, or you could get a worthless opinion. A cue is not a fact or an opinion, but it's something that's pointing you in. It's like a clue. Think clue, cue as clue. So it's kind of a clue pointing you in the right direction, but it could also lead you off track. And an inference is something that you, based on something you see or hear, you infer something that you don't see or hear, but that's based on that. For example, if I'm walking along and if I go by your house and I see in your garbage you've got beer cans in your garbage, why I'm going to say, oh, well, that person drinks a lot of beer. Now, maybe that's totally wrong. Maybe for some reason there's a lot of beer cans in their garbage and they don't drink at all. But so an inference can either be work out and be true, or it can be false as well. Do I ask for more information or clarification if I don't understand things? And that's a big that we're often embarrassed to ask, or we're pressed for time, or we're frustrated with the person and don't want to ask or don't want to have more conversation. So that's something that we often fail at. Do I validate information or judgment with experts? And expertise is something relative. Like there could be like a national expert on a particular disease who works for the CDC in Atlanta, but your local pharmacist in your hospital is your local expert on medication information, or maybe just a fellow student who has lived with somebody with Crohn's disease for a long time, may be your local go-to expert for Crohn's disease. So if an expert can be anybody that knows more than you do about something, but they're not infallible. Certainly they can be wrong too, but you'd be wise to use your experts. Do I use past knowledge and experiences? So a lot of times we think that, oh, this is nursing, this is a whole new field. Maybe you had, and when you remember in Intro to Nursing, you had somebody from the Career Center that came over and talked about how to market yourself. Maybe you had experience doing customer service and you got to where you gave excellent customer service at a helpline you were working on. Well, you can probably use a lot of those skills in nursing and use those to good effect. Or maybe maybe you have knowledge, maybe you were doing like, some engineering things before and you're on a second career. And so you have some past knowledge about pressure and resistance. You can use that to great effect in order to understand the heart and the systemic circulation. So make use of all that past knowledge and experiences. Then, do I try to avoid biases and preconceptions? A lot of times we do just the opposite. We uh, embrace our biases and preconceptions. Like if you're, maybe a fierce Democrat or a rabid Democrat, why you're going to, and you pick up a magazine and you see an article that supports a Republican or something like that, something like that says Ted Cruz, the next great U.S. Political phenomenon. You're going to maybe throw that article away. Oh, I don't want to read that. And then if you find another article that says Ted Cruz is a bad person, oh yes, let me read that. And certainly if you're a rabid Republican, you're going to do just the opposite. You'll get the pick up the article that praises Ted Cruz, and that one that criticizes him, that's trash, that's false news. And so we often do that not only in political areas but in other areas of life too. Like if you're convinced that your patient has a certain nursing diagnosis, you may seek out the things that confirm that and ignore the things that don't confirm that. What's worse is if you sometimes, I knew one doctor who he was always looking for cases of deviated nasal septum and finding and relating just about anything the person had to that deviated nasal septum. And I suppose he had some early successes in treating patients by correcting that and improving their lives, but by the time I knew him, why, he was like, he just about anything you might mention, oh, they probably have a deviated septum. Let's look, if we correct that, do surgery to correct that deviated septum, that problem will improve. It was like he was biased in that direction by his past successes or past experiences. Then, do I learn from previous mistakes? That's big. A lot of times we try to forget our mistakes, but really and truly the best thing to do is to learn from them. And am I open to the fact that I may not always be right? That's a very hard question for all of us as well. So the steps of the diagnostic reasoning process are first to identify strengths and abnormal data, then to cluster data, then 3, draw inferences, then propose possible nursing diagnoses, then check the defining characteristics of those nursing diagnoses that are possible. Finally, confirm or rule out the diagnoses, and then document our conclusions. But before you even begin, don't even begin the diagnostic reasoning process unless you're sure that your data that you're using is sound. I'm not saying that everything has to be 100% because there's always some little doubt, but make sure that your data is sound, and then make sure that it's relatively complete. Now, after you begin, you may notice some data that's questionable or data that's incomplete, and you can still proceed. You just need to go back and see if you can either get more data or validate the data, or if it is incomplete and maybe a little questionable, then you have to realize that your diagnoses are only going to be as strong as the foundation they're built on. I mean, if uh, you may go, if you're building something, building a building, a house or a building, you want to make sure about your foundation. And in the end, maybe you get to a situation where, this foundation can't be made 100% secure, but we do need to proceed. So we've got to be aware that in the case of a hurricane, this house is probably not going to stand. So step one, identify strengths and abnormalities. And the most important thing for this part is you've got to know what is normal. So you're going to rely on your knowledge base of normal anatomy and physiology, and you also need a lab book or a diagnostic book or some reference that will tell you what lab values are normal, what vital signs are normal. So you need to know what's normal in order to know what's abnormal. You're also going to need a basic knowledge of risk factors for a number of problems, like risk factors for diabetes, risk factors for hypertension, risk factors for falls in the elderly, risk factors for all the different things that we screen people for. And there are new ones constantly coming up, like you may learn all these risk factors, and then maybe more further research comes along that says, well, some of those risk factors aren't as important as we thought they were. Other risk factors are that we previously were not aware of. And then here, by the way, here are some other things we're going to start screening our patients for. So that's something that is a challenge to keep up with as well. And when you are identifying strengths and abnormals and risk factors as well, you're going to analyze both the subjective and the objective data. Like maybe the patient told you, well, I had such and such disease, and that's going to be a factor that in maybe some of the risk factors or maybe some of the strengths or weaknesses. And then also the objective data, things that you saw on your assessment. So then step two is clustering the data. You're going to look at what seems to be related, and this can be a little bit tricky because not everything that seems to be related is, and there might be some things that are actually related that don't look like it at first, so that can be a little bit tricky. Cluster both the abnormal cues and also the strength cues, so you want to cluster both. And you may find that there are cues that support a problem, but there's not a lot of them, and there's some gaps, and you need more information. So you may need to go back and do some more assessment, gather some more data. Then drawing inferences is step three. So first, just jot down, not in the chart, but just jot down somewhere what you think the data is saying. Like maybe you know of a couple nursing diagnoses that are related to an area, and you think, well, I think this patient has, I think her body image is altered, so I'll put down alteration body image, but then later you think, well, maybe it's not her body image so much as her self-concept, and so then you might jot down both and say, well, I'll look it up in the book later and see which one she's most closely, or maybe she does have a little bit of both. So then determine, well, can a nurse treat this independently? Yeah, well, self-concept and body image, we may eventually need to refer it to a psychologist or somebody, but we can take the initial steps anyway. And then you'd want to identify you would either, it's going to either be a possible actual diagnosis, collaborative problem, or a referral. And the difference between that is an actual nursing diagnosis is something that the nurse can treat independently. A collaborative problem is something you're going to need some help with, but you still would be quite involved in the case. And a referral is something that you're not going to do much at all. You're going to hand the problem over to somebody else who has more expertise or who can treat the problem. Referrals can also be, they can be for things that you could treat, but there's somebody else that has more expertise. And the example maybe could be, well, I know how to do trach care, but the respiratory therapists do it better, so I'm going to refer this problem to them, to the respiratory therapist. Propose possible nursing diagnoses. And we have various types. We have wellness diagnoses, and those are going to look like readiness for enhanced nutrition, readiness for enhanced exercise. So they'll have those words, readiness for enhanced. And it's something that's not a problem, it's actually a good thing. And it'll be related to a certain factor, like they expressed interest in it or something like that. And this can be either a client thing or a family thing, but they're motivated to increase their well-being. The flip side of that is a risk diagnosis, and this one is something that hasn't happened yet but you're afraid might. Like say falls, infection, impaired skin integrity, whatever. Risk for something related to. And that's the way that's going to look. It's a vulnerability to a problem the patient does not yet have. An actual one is a current problem, and that one has three parts. Impaired something, or some problem, then it's related to something else, and it's as manifested by something else. So for the risk and for the wellness, you don't have as manifested by, because there's nothing, it's something that hasn't happened yet. For an actual problem, you do have as manifested by, because that's your evidence that the person actually has this problem. Like say, if you have confusion related to what do you think's causing it? Well, I think that it's her hypoxia. Confusion related to hypoxia as manifested by, and that gets tricky because a lot of times students will put in the evidence for the hypoxia, but you need to put as the evidence for the confusion, as manifested by she failed her slums test. And usually it's when I'm grading care plans, it's very easy, like students will sometimes put risk for something related to as manifested by. So that tells me that either the student has put as manifested by that doesn't really is not really evidence for the problem, or the student has put an actual problem as a risk problem. But I can see right away that there's something wrong there. Then we also have syndrome nursing diagnoses. These are not as common. They're a cluster of nursing diagnoses that are related in the way that they occur in a way such that they occur together. And one of them is disuse syndrome, which might be, say, somebody fractures her or his femur and is in traction for a while, so they're not using that extremity, so they're going to have some changes in bone, changes in muscle, changes in activity. They'll have risk for pressure ulcers. They'll have various things that happen. And frail elderly syndrome, which frailty is Frailty is just generalized weakness and debility in the elderly. Pain syndrome, which would be not only you have diagnoses of acute or chronic pain, but in pain syndrome they have changes that affect various systems of the body as a result of pain. So that's a broader diagnostic category than just pain, acute pain or chronic pain. Post-trauma syndrome. So that would be, syndrome is, okay, post-trauma syndrome. So that would be somebody that received some trauma, whether it be physical, psychological, whatever trauma they received, and they have a number of effects that affect various parts of their life, various parts of both physical, emotional, mental, various parts of their life that they're affected by that. Rape trauma syndrome would just be a variant of other post-trauma, but it's more specific to people that were raped. And relocation trauma would be, many of us relocate all the time and we don't have trauma, but sometimes if you relocated, say, following a hurricane that was devastating, or following a war, or following some event like that, or if the relocation was forced or something, and maybe it wasn't all that dramatic, but maybe your children pressured you into selling your house and put you in an assisted living facility, and the outcome wasn't good. And then sudden infant death syndrome, which you'll learn about when you get to PD. Step 5, check the defining characteristics of the diagnoses, because their diagnostic labels will often overlap, like you might, like I said, role function, alteration in role function, maybe alteration in self-concept. There might be some overlap there, or alteration in body image and alteration in self-concept. So the thing to do then is go to the defining characteristics, and that's the observable evidence that you're using to support the diagnosis. And when you get the NANDA textbook, which you'll probably have to get from the library unless you happen to have one, why, you'll see that each diagnosis also has a definition, and they have these defining characteristics. So those two things, the definition and the defining characteristics, are what's going to help you to decide which one is the best. And it'll also help you rule out a diagnosis or rule it in. You have your Lippincott Advisor for healthcare, which is available as part of that's in your foundations among those course point books, and that will get you part of the way, a long way, because you can look up different conditions, different medical diagnoses, and find possible nursing diagnoses. But unfortunately, that Lippincott Advisor is not going to give you either the definitions or the defining characteristics, so you'll have to find those somewhere else. And I would recommend a trip to the library. Confirm or rule out the diagnoses. Use the definitions and defining characteristics in this step. And then another thing to do would be to verify with others involved in the person's care. Now, that is not necessarily, that wouldn't be your first step. Your first step would be the definitions and defining characteristics, because you might get an experienced nurse that is very knowledgeable and ask her to come over, but she may be kind of rusty on nursing diagnoses and on definitions and defining characteristics. So she might just, oh honey, just go with altered role function. And she may or may not be a good source for that. Also discuss the matter with the patient. Now, you're not going to go and uh, give them the nursing diagnosis terms. You're going to have to put it into terms that they understand. But you'll be saying, well, the way I see your problem is blah, blah, blah. And then they may or may not confirm what you're understanding. They may have a very different understanding. That doesn't mean your understanding is wrong, but it's nice if you and the patient are on the same page. That's not always going to happen because sometimes patients will have a very different outlook and different, sometimes that gap can't be bridged. If the patient has altered mental status, then you'd want to consult their family or someone else. And then validation is especially important with collaborative problems or referrals, because you would want to, if you're referring a problem or you're going to collaborate, you'd want to make sure that you and the other professional are on the same page about the problem. And again, they may or may not be familiar with nursing diagnosis terms, so you may have to rephrase things into terms that they understand, their perspective. Document conclusions. And you're going to follow hospital policy, which a lot of times in the hospital they won't have you do a complete 3-part NANDA format actual diagnosis. They may just have the first part in the chart. And they maybe just have the first and second parts. But whatever it is, you would follow the hospital's policy. But NANDA actually calls for 3 parts in the actual diagnosis. You have a problem, which is the STAM, like impaired skin integrity. And then it's related to something, and that would be the cause. This part can occasionally be omitted if you don't know the cause, but I would even then put related to unknown cause. And then it's as manifested by or as evidenced by. AMB stands for as manifested by. And that's your evidence. And so again, that evidence is supposed to point back to the problem, not to the cause. It shouldn't be pointing to the related to part. It should point to the actual problem. Like, what were the cues? And you might have 20 different cues. You're not going to put all of them, but you just put 1 or 2 of the most important. And like I said, this last part is sometimes omitted, but you would not want to admit it on anything you turn in at UT Arlington. But if the hospital wants you to omit it, go ahead and omit it. But for us on tests, look for that last part. Risk diagnoses. They will only have a problem related to a cause. They don't have as manifested by, because a risk diagnosis is something that has not actually happened yet, so you don't have any evidence for it. You just have a cause that puts the person at risk, but you don't have the evidence yet because it hasn't happened. Collaborative problems are going to start with R/C, and that's risk for complications. And they may or may not be followed by the related to. So you'll have and then and also referrals are also written the same way. Either collaborative or a referral is going to be written the same way. And you may not really know when you first call somebody the difference between a collaborative problem and a referral is that with a collaborative problem, the nurse is still involved, monitoring, doing some, helping with the problem. With a referral, the nurse just hands the problem to somebody else. And you may not know, because you may think, well, I'm going to refer this, and then the person you're referring to says, well, actually, I'd like you to continue to monitor, do this, this, and this. So it ends up being a collaborative problem. and or you may think it's going to be a collaborative problem, and you call and the person says, oh no, well, we've got to move that person to ICU right away, and we're just going to or we're going to take them to the cath lab right away. So then that would end up being a referral. Health promotion diagnoses are going to start with readiness for enhanced something, and they may be followed by related to something. And again, those are not going to have as evidenced by or as manifested by, because it's not something you can see yet, though. You certainly have a reason for a cause for them to be ready for the enhanced, but you don't have you can't see the enhancement yet because it hasn't happened yet, just like the risk. So developing expertise, unfortunately, it takes time and experience, and there's no way to just bottle time and experience and purchase it at the store or something. Accurate diagnoses are diagnoses that are precise, they're specific, they just zero in on the problem, and they're well supported by relevant cues. Beginning nurses, you as is the nature of the things, you lack knowledge and expertise, and beginning nurses will tend to focus on details and rules, and they ignore the big picture. And the thing is that, like, a lot of times beginning nurses or students will hear something that's said, and they think that it's something that maybe applies most of the time, and then they don't consider that just about everything has some exceptions. Experts, on the other hand, they're going to recognize when exceptions can be applied, and a beginner is going to have a big problem with that. That causes the beginner cognitive dissonance. It kind of confuses the beginner and is quite stressful. I'm sure you have experienced this in class when the teacher says things and then you apply, or you're thinking you're applying that rule, and on the test, and then you get a question wrong, and maybe the teacher gave a good explanation, maybe the explanation wasn't that great, or maybe the explanation was okay but you just couldn't capture it. And the same thing happens in life too. However, beginners can improve their performance by knowing what not to do, by knowing what to avoid. So, some of the diagnostic pitfalls would be too many or too few data. Think too many? How can we have too many? Well, have you ever, gotten so much information that you couldn't see the patterns, and then you took the test and you did poorly? This can happen with diagnosis too. You can get so much data that you miss seeing the patterns, and I think if that takes judgment to see, well, what is the important data here and what's the unimportant data. Like if you document, the color is pale tan, and the pupils are reactive, and they move through all the cardinal, move their eye movements through all the cardinal, and so you keep going on, and then there's a few significant things in there, but they're buried under all of the details that you provide. And those few significant things are not highlighted, why then that can be a problem. And then too few data is the other problem. Like maybe you rushed through parts of the process and collected too few data, didn't pick up on that in the clustering step, and so then you tried to create a diagnosis or tried to find a diagnosis based on too few data. The other pitfall would be unreliable or invalid data. Like maybe you asked some things and the patient didn't misunderstood you, either due to language barriers, due to maybe you were using leading questions and led them into saying things that they were invalid. So if the data is unreliable or invalid, like maybe those vital signs you're basing it on, you didn't take them, maybe somebody else took them and they got the wrong patient and they're telling you, oh, his vitals are 80/60 and heart rate is 120, and you're panicking, oh, he's in shock, and it turns out that the patient next door is in shock, but he's not in shock at all. Insufficient cues to support the diagnosis, where you have some cues that are pointing one way but they're not sufficient to support it. Another thing you can do is you can sometimes cluster cues that are actually unrelated, like maybe you have an irregular heartbeat and then you have some shortness of breath, and you think, oh, you know, I bet this person maybe has some heart failure and that's causing the shortness of breath. And so that certainly can be the case, but sometimes shortness of breath is caused by other things, by say a respiratory thing, and maybe the person has an irregular heart rhythm but they aren't in heart failure at all. So that's an example of how you could falsely relate cues that are not really related. And then you could also, of course, fail to relate cues that should be related. Like maybe you think, oh, that respiratory shortness of breath is respiratory, and so it can't be related to the cardiac symptoms I'm seeing. So that would be the opposite error. Your diagnosis can be made too quickly without considering other possibilities. Remember when we said to cultivate critical thinking? Think about other possibilities. Even though maybe something seems obvious, just think, well, could this be from some other, is there any other scenario that would explain all these findings? Diagnosis can be poorly worded or not very communicative. So it could be the right diagnosis, but it's poorly worded. And diagnoses may also fail to take cultural considerations into account. So that maybe you think, oh, this woman has a poor self-image, and that may be a cultural thing where, yes, she does by our standards, but maybe within her culture it's a normal self-image for women. And so that could be something to consider. So that concludes Chapter 5.